So finally, before we enter our discussion section, we have John Graykowski, who is the Director, Physician Assistant, Nurse Practitioner, Emergency Services at the Mayo Clinic Health System. And he's going to be speaking about rural strategy to reduce drug diversion.
Great. I really want to thank everyone on behalf of SAMPA. The Society of Emergency Medicine PAs has been invited and actively participated in planning with this. And as we are with ASAP on many levels, we share responsibilities and participate in many of the initiatives. So we're really very, very grateful for it. I normally say I sadly have no disclosures. I actually do today, and that is that I have nothing new for you. There's nothing that I have that's going to change your practice, I'm afraid. What I'm basically going to be sharing with you is just our own process in trying to deal with a problem that we encountered in our emergency rooms. So I think one of the things that I want to share is that we are basically a rural community in Wisconsin. We have 4 hospitals that are critical access. Their annual volumes run anywhere from 1,500 patients, don't you wish you had one of those, up to about 13,000. And we have a tertiary facility that sees 30,000, and that's our primary referral source. I don't know if any of you have seen Emergency Physicians Monthly that just came out. Rick Bacata had some comments about the role of PAs and NPs. Mayo has adopted a system of emergency care in our 24 hospitals in the Midwest, where any of our hospitals under 8,000 visits are staffed primarily by PAs and NPs, with telemedicine being the resource for consultation. And we have a very extensive program for education, ongoing training and supervision of those folks. So we speak from that experience. Looking at our critical access hospitals, we found probably between 15 and 20% of the people who were coming to us really were coming to obtain narcotic drugs, bottom line. And our realities, addiction, not so much. In 8 years of working in emergency medicine in rural Wisconsin, I actually had one person who showed up, actually an active withdrawal from intravenous drug use. But for the most part, we have the same problems that most everyone else is experiencing. More of a dependence, suppressing emotional pain. It's a horrible thing to be a 17-year-old raising a child on your own, working at McDonald's, trying to go to school and not getting any support from your alcoholic parents. Yes, I know that's a kind of a cumulative picture of a problem, but you know that you run into that every day and worse. And for better or worse, narcotics are wonderful painkillers, and emotional painkillers are certainly one of the reasons I think people come to us. But really, for us, where if you're making $12 an hour in rural Wisconsin, you're kind of the upper crust. And the reality is that, like most rural parts of our country, income is limited, and yet people have constraints. We always find that we have increased drug seeking, increased complaints of pain right around Christmas time, when people are trying to get their Christmas gift spot for the kids. Summer's another big one, when they want to take the family out to the Wisconsin Dells for a weekend on the water. And at roughly what we're told, one of our Vicodins goes for $8 a tablet on the street. So this is a nice income augmenting process. The other thing that we have in rural America, and again, you've experienced this in many ways wherever you are, the realities of resources, 12-step programs. We have AA. I mean, there are a lot of groups that meet. For those of you who have worked with people with substance abuse problems, drug problems, narcotic problems, they generally tend to not feel comfortable in AA meetings. If you're fortunate enough to have narcotics addiction meetings, that could be helpful, but we don't. Drug treatment, if you're lucky enough to get arrested, you can enter a drug treatment program that's run by the probation department, which is pretty much limited to monthly urinalysis checks. We do have residential treatment. There are a couple of places on a lake, that for $60,000 for a 30-day treatment, they'll be happy to take care of you. Or you have the Gospel Rescue Mission in Eau Claire, Wisconsin, which is an interesting place. Most people don't go there unless they're under pretty significant pressures or they need a place to stay for the night. Everything else, significant distance and big expense. I have to share with you that our tertiary hospital, with about 30,000 visits a year, actually did a sort of a process that engaged, it was wonderful. There was a triage screening that was done. Once the patient got into the room, somebody was looking through their medical chart, counting up how many ED visits they had. There was a much more sophisticated self-assessment that they were asked to do before they saw the provider. Then after seeing the provider, the social worker would come in and talk with them about it. And what we did find was that it lasted about 30 days. At which point the nurses said, we really don't have time to do this. And there were a couple of reflections on it. You're all familiar with the old saying, don't try to teach a pig to sing, it annoys the pig and frustrates you. Now, there are days, on my more cynical days, when I'm more than happy to to annoy the people who are coming in and whom you know are looking basically for drugs. And have no underlying medical condition that would prompt the treatment of that. And so annoyance works really well on people who are looking for drugs to sell because they're businessmen. And if they're not going to have any luck with you, they want to go down to the next ER. But the other thing that for me is, as I share both administrative and clinical responsibilities, it's this frustration part. I don't like my providers to burn out. And there's nothing like sitting there trying to have a conversation with somebody who's trying to scam you out of drugs to make you feel like maybe you should have been selling Amway products instead of going into emergency medicine. So it is a big challenge for us. We undertook a process to establish a guideline. The guideline was never able to go into a policy statement with us because everybody said, well, we're here to treat pain. We're here as medical providers. We don't want anything that's going to interrupt or interfere with our prerogative to treat as best we can. So we don't even pretend to do that, but as such we keep it as a guideline. This provided us an opportunity to speak with all of our providers about the role of medicine in keeping a supply of drugs going into the community. And when we had this discussion about just how many prescription drugs are being diverted and how we dwarf the Medellin cartel, and people suddenly saw a connection between those 30 Vicodin that they quite innocently wrote for and the broader problem of drug diversion in the country. Most importantly, and I'm not bothering to read this, all of this is, our guideline is actually in the handout. I think it looks pretty good. It's worked very well for us. Well, we basically understand that pain control is really a multifactorial function, and it is best done in relationship. That relationship doesn't take place in the emergency room. So we acknowledge right up front that chronic pain management is not an ED function, and then we also really work with our family practice colleagues within the community to make sure that drug contracts are in place and that there's a clear understanding among all of us of how we're approaching the problems of pain and chronic pain in the community. Now, we didn't just develop a guideline and say we're not going to write for prescriptions for Vicodin anymore or Percocet or what have you. We kind of looked at other ways that we can treat pain. I have no interest and no vested financial interest in this product, yet every one of our emergency rooms has this, and all of our providers check out on doing dental blocks, and we encourage the use of dental blocks. And as you know, I have a history of working with injection drug users. Every one of them has a fear of needles. And so when you offer the person an option of a dental block and they say, oh my God, no, I'm afraid of needles, they're kind of self-identified, I think. But anyway, the bottom line is using things like dental blocks, we actually will go ahead and do temporary fillings in our ERs. Some of that is going to be limited by time, but nevertheless, it's an important resource. I picked out just a couple of really good YouTubes that we use as part of our training, looking at regional nerve blocks, trigger point injections. Some of our colleagues have really done some great training tapes on these things that are easy to look at and figure out. Migraines, we're introducing cervical injections right now. Again, I refer you back to Dr. Larry Mellick's recent article in Emergency Physicians Monthly. Occipital nerve blocks. Again, for people who are having pain, these resources give relief. It is really gratifying to take somebody who is accustomed to coming in, to getting an injection of morphine, going home, to be able to sit and say, this is going to work for you, have them receive the injection and have their eyes light up and say, this is the first time I'm actually pain-free. This stuff works. And so we wanted to expand our armamentarium of treatments that would be effective in really addressing these issues of pain. And of course, our physical therapy department just got our first acupuncturist. I come from California originally, and I was fortunate enough to have an acupuncturist in the emergency room. As soon as somebody came in with a back pain, they called the acupuncturist before they called me, and this person was already receiving a treatment by the time I got to see them. But really trying to integrate alternative methods of dealing with pain and chronic pain, because a lot of times, even in the family practice setting, these are issues that are not dealt with very well. It's either to medicate or not to medicate, and the reality is physical medicine probably works on a lot of the chronic pain much better than anything else. So anyway, the bottom line is that we went through a process to actually engage our providers, understanding what our principles and values were as medical providers, and obtaining consensus. One of my colleagues in southern Minnesota actually did the groundwork, the community organizing, where he met with each individual emergency physician and groups of physicians and other providers, and actually moved this policy to a policy level that was voted on by the medical staff so that it has a little bit more teeth. And we have a clinical practice committee for Mayo in the Midwest in emergency medicine, and so now we're looking at applying this policy across all of the 24 hospitals, depends on which acquisition we had this week. And I think there is a lot to be said for the time you spend in being honest with patients and trying to have the discussion. Like I say, those folks who are going to get annoyed, that will be clear soon enough. And then we do really try to empower our providers. And so far, we have seen a fairly significant reduction in the folks who are coming in to get the refill on their pain medication to, this is the 14th ankle pain that they've had in the last year. That stuff is actually drying up. And because we kind of control the market in the area, they're having to, I guess, travel quite a bit. I don't know. This is the grandson of one of my dogs. We're not abusing him here. He's actually works with autistic kids and desensitizing them from scary activities. In this case, the scary activity is going to the doctor. And they're very happy with the work that these assistance dogs do. I think we would do well to have one in the emergency room. One last disclosure, and I said I had nothing new to tell you, and that is why. I do work with JACO, and the 5th vital sign is now going to evolve into the 6th vital sign, so that we'll be assessing at each visit drug diversion potential. And I'm unveiling today the new visual scale. We have order forms available. You can actually get this. Is very handy. You can wear them in the ED. The patient just points out to whatever happy face they're feeling at that point, and on the back there's a little description of whether they are in fact seeking drugs for resale or not. Thank you all very much.